At the outset, I would like to thank our eminent faculty for joining this important webinar. I welcome our delegates from all over the country coming for this very important topic on COVID-19 and GA emergency. We are in a very difficult time of COVID-19, facing a lot of problem now, managing elective cases and the emergency situation. Luckily, our people and our medical fraternity have understood that this time we will not be dealing with the elective cases. We could postpone elective cases for some time, but emergencies cannot be postponed. That's the reason we have chosen this topic, COVID-19 and GA emergency. I welcome delegates to for this important webinar. And this COVID-19 and GA emergency, this webinar is being conducted under the auspices of Tamil Nadu Dr. MGR Medical University, Tamil Nadu Medical Council, and Tamil Nadu IMA. I bring warm greetings from MedIndia Hospital, Chennai, which has organized this important webinar. This webinar is going to deal with how we have tackled GA emergencies for the last 1 year during COVID-19 pandemic. My pleasant task is to invite our eminent faculty now. Dr. Ramakrishna, Dr. P. Ramakrishnan, I welcome you, sir, State President of IMA Tamil Nadu State Branch, and he is the Chairman of Sri Venkateswara Hospital. He has got over 3.5 decades or 4 decades of experience in surgical specialty. Nice to have you as our panelist, sir. We welcome you. Now I welcome Dr. Ravi Kumar, who is a surgeon, and he is the Honorary State Secretary of Tamil Nadu IMA branch. He is the Chairman of Mouti Nursing Home, Coimbatore. We welcome you, Ravi. And we have another panelist. It so happened that all our speakers are medical gastroenterologists and all our panelists are going to be surgeons. I never realized that when I fixed it. So there's going to be a very nice discussion about medical plus surgical, not medical versus surgical in this webinar. I have a great pleasure in inviting my good friend, Dr. Jailal. And he is the National President, Indian Medical Association. He is a Professor of Surgery, Tirunelveli Government Medical College Hospital, Tirunelveli. I have known Jailal, very hardworking medical doctor. He has been traveling widely for the cause of IME and for the cause of medical fraternity. Now he has taken over as the president in the difficult times of COVID-19. That means he's got several tasks to undertake. One as a president and as an advisor to the government of India and government of Tamil Nadu, and as an advisory panel, how to combat this pandemic. I know in a difficult time, but you have been doing extremely well. Congratulations, Dr. Jailal. And with this introduction, I have a pleasant task to tell you that this COVID-19 and GA emergencies, the webinar would not have been possible with the academic grant from Torrent Pharmaceuticals now. Now coming to the GA emergency during pandemic, why should we discuss about this COVID-19? You know, there are a lot of issues in this pandemic, starting from resources depletions to the manpower problem, and if you don't tackle this emergency, there's going to be problem increase in the mortality. We have never heard of this pandemic. We have only read in the medical books that pandemic, but 2020 we came to know that the pandemic, we were groping in the dark. We did not know what is this virus, how does it come from. In 2021, we are now grappling with the evolving scientific knowledge. And we have really achieved the great diagnostic accuracy as far as the COVID-19 is concerned. And now we have come to the level of at planning the treatment from hydroxychloroquine to triaging, oxygen, antiviral, and monoclonal antibody. Before going to the topic proper, I would request now our the President of National IMA to deliver the inaugural address. And having introduced the topic, I may request Dr. Jayalal to give the inaugural address.
Thank you very much, sir. Distinguished the great scholar and the veteran gastroenterologist, Professor Dr. T.S. Chandrasekhar, the President of Indian Medical Association, IMA Tamil Nadu, Dr. Ramakrishnan, the Secretary, Dr. Ravi Kumar, the eminent panelists, Dr. Prasad, and other distinguished members. I'm extremely delighted to be part of this wonderful webinar, which is being now hosted by the well-known great gastroenterologist, Dr. Chandrasekhar sir, on this COVID pandemic. We all know the COVID is one predictably unpredictable disease, and every sector of the specialty can talk about the symptoms and aftermath and the complications of the COVID. Previously, we used to say when you know something about, about COVID, I mean diabetes, and you can study entire medicine. Now the reverse has come true with when you study about the COVID, and you can study every specialty and every super specialty in that. So many webinars are taking place, but this is quite special because we know what Dr. T.S. Chandrasekhar sir is doing to this fraternity and the community. A veteran person, it is to his credit. He has all the honor a doctor can dream in this world is with him. Whether he has the top level degrees of the DM and DSC, the Doctorate of Science from our prestigious MGR Medical University. He has a FRCP from all the 4 colleges of UK. That is a great achievement by any learned colleague. And his contribution in every year in a different innovative ideas. And very recently, what he had in the artificial intelligence and obesity, and all this speaks volumes of his contribution to the medical education and medical fraternity and for the welfare of the community. And today he is bringing out with a very important topic of the COVID and the GI emergency. COVID, not only per se it caused the GI emergency, but also because of the social concerns, the lockdown, the difficulty of the people to moving around, the people's perception that hospital is a hot zone for them. When they come, they will get the disease. All make the people come to the hospital very late stage. And even apparently a normal conditions are becoming as an emergency condition in the settings of this COVID today. And we see in the clinics and the many people coming with, if at all they have a pain abdomen, they just try to neglect it. Only when it becomes a perforation and they produce a septicemia, they come. The pancreatitis, when it is becoming a fulminant one, they are coming to the hospital. And even the bleeding, GI tract bleeding, hematemesis, we are rampantly seeing that the cases are increasing. There's one way the ignorance is still there on the people. They try to see that everything is there, is a gas, bloating or something they can attribute, and they try to postpone it. Probably also the environment, the situation, or the financial conditions, making them to cope up with the early symptoms and not recognizing the red flag signs and still coming in a very, very late stage of the hospital, and the mortality and the morbidity resulting is very increasing. And we, for the medical graduates also, for the medical fraternity also, we need to know more about the red flag signs and how to identify these diseases at the early part. And that also has to be in one of the very important arena which all we need to know. In the first way, we all know when there is patient comes with the gastrointestinal symptoms like loss of taste or loss of smell. And every one of us were happy because most of the cases, 99.9% of the cases which presented with loss of taste or loss of smell never went into a serious COVID. And that fortunately they were having only a mild, the maximum, the moderate symptoms. But that was not so in the second wave. Even with the people come with the gastrointestinal symptoms, we are getting a severe cases. And people with the gastrointestinal symptoms, especially diarrhea, when they come, they behave like a super spreader and the entire family is getting affected. And that is all this we need to understand in the recent development concept and how we are going to do that. But I am interested on the post-COVID complication. We are setting now patients who go for the post-COVID era. They get cured, they get symptom-free. But after 3 months, after 2 months, they are coming with a lot of problems associated with mainly lungs and heart. But we get a lot of people coming with the post-COVID gastrointestinal problems They have many times the people come with the bleeding. Probably still they continue to use either the heparin or the anticoagulant. They come with the perforation. The incidence of perforation with the people coming with the post-COVID is increasing. Retrospectively, we see that many people still continue to use these steroids. So there is a lot of cases we get in a post-COVID emergency as a GI tract problems. Is an aftermath either due to the disease or due to the treatment modalities which they are following. So these all are the challenge now in front of us, the every medical fraternity. I'm so happy that Dr. T.S. Chandrasekhar has taken this very important topic of teaching, educating, and hand-holding our medical practitioners to understand the COVID-related GI emergencies, whether it is from the esophagus, whether it is from the colon, or whether it is from the pancreas, and how to identify the red flag sign, how to go ahead, and what care every physician should take care when they are prescribing the medicine, especially continuation of the anticoagulant, the steroid, and what are the advice which we need to give to the people to understand the complication related to that at the early part and come to the hospital. So all this, I'm sure this webinar will give us a very, very lot of input. And as he has started with his introduction, he's going to talk about the monoclonal antibody treatment, because now it is every one of us is looking for that, and we are getting a relatively a good report and good results with that also. So a latest, but the basics, both this combined together is the art of Dr. T.S. Chandrasekhar sir. I had the privilege to listen to many of his lectures. He will never only talk about what is on the top or the highest advanced, but he will always start with the basics and make the people to understand the foundation of understanding the subject. So that is a hallmark of T.S. Chandrasekhar sir. I'm sure in this webinar also he will do that, and the people will be able to understand the concept in a holistic way, will be able to benefit. I always used to say in any CME, it is when the knowledge is given to doctor, the ultimate beneficiary of that is the patient. So today, Dr. T.S. Chandrasekhar sir is doing human social service, because what you teach us, what you give us, will definitely it will be benefit our community and the people who are coming with the difficulty. Thank you very much for the opportunity. Indian Medical Association headquarters profusely thank you and congratulate you for this wonderful service you are doing for our medical fraternity and the community. Thank you, sir.
Thank you, Professor Jailal, for your kind words about me. And I know that we have been associated for the last 2 decades and more so, and several IMA meetings and the surgical seminars we have participated. I thank you very much for this. And highlight of your speeches, I recall by board professor in Madurai Medical College telling, if you know syphilis, if you know tuberculosis, if you know diabetes, you know medicine. Now you said if you know COVID-19, you know medicine. You rightly said it so. And the second thing is all the benefits of CME ultimately will they percolate to the common man and through the medical fraternity. So the duty and responsibility of all medical fraternity who are in the higher pedestal to conduct such a CME. I'm very glad that, and around 40 webinars, the CME of my program have been conducted under the auspices of Indian Medical Association. I must really thank the Indian Medical Association and the current president, Dr. Jailal, for giving this opportunity. Thank you, sir. I will start the lecture now. Thank you. And thanks for gracing the occasion as the guest of honor. Thank you. And I wish that you are with us some more time to listen to the talk. Okay. I was telling you that we were groping in dark, and now we are having plethora of information about the SARS COVID virus 2 virus, that is the SARS, that is severe acute respiratory syndrome, coronavirus 2, hereof will be referred as COVID-19. And you see the completed diagram, how the scientists have identified S1, S2 protein. And the most important thing is the ACE2 receptors through which it attacks the various organs in the human body. This is a very important discovery, and we are able to currently advocate certain medicine depending upon the life cycle. We know the life cycle of roundworm. We would not have thought of in 6 months, we would be knowing the life cycle of COVID-19 virus. Now, ACE2 receptor is not only seen in the respiratory tract, but also seen abundantly in GI epithelium, liver, and biliary epithelium also. That is the reason why GI tract is also affected, because the entry receptor is universally present, and not only in the respiratory tract, it also in the GI. And moreover, over a period of 4 to 5 weeks, the virus can be excreted in the stool, even after negative respiratory sample. That indicates that viral setting is happening for quite a bit of time. Whether fecal-oral transmission is possible or not, yet to be understood. Now, coming to the GI emergency, we have to understand the GI symptoms in COVID-19. Over 49% of the people have GI symptoms in addition to respiratory symptoms. Predominantly, they did have anorexia, diarrhea, vomiting, and abdominal pain. And the digestive system, there is a very important study has indicated that those without GI symptom recovered faster than those with the GI symptom. That means it indicates those who had GI symptom means the recovery was prolonged and they had more complications. It is noteworthy to remember that 4% of the people had come to the hospital and presented only with a GI symptom, they are positive for COVID-19. With all these things, we understood higher rate of GI symptom in severe COVID-19 infection, number one. If the patient is admitted with the COVID-19, there is a new onset of GI symptom means severe disease. Now, coming to the GI emergencies, we have categorized into 4 areas: GI bleed, hepatobiliary pancreatic, luminal, and the small intestine colonic, and acute abdomen. That is a very important aspect of our Now, what I have done here is the most important slide to understand this COVID-19 GI emergencies better. I have categorized into several, made it into several headlines. One is directly COVID-19 producing GI emergency, directly or indirectly, or a pre-existing GI disorder presenting as emergency during a pandemic. Certain drugs being used in COVID-19, steroid and remdesivir, anticoagulant, etc., can produce some GI emergencies. Like steroid can produce pancreatitis, remdesivir also known to have a rare incidence of acute pancreatitis, and anticoagulants can have hematomas. COVID-19 is mimickers. What do you mean by the mimickers is they did have lung symptoms mimicking as COVID-19, but they did have the GI emergency. How to handle this thing? This is all internationally reported cases and emergencies among pediatric population. And how do you handle GI surgery and endoscopy in COVID-19? And the last 2 important items is there any difference in handling GI emergency in COVID-19 positive patient or a negative patient? How do you manage such a situation? Let's listen to one by one now. Due to COVID-19 directly and indirectly, let me go through this. The GI bleed during COVID-19 pandemic can happen because of the anticoagulant usage. Certain medications like the painkillers and steroids or antiplatelet drug or a high, and the stress-induced reasons also may be the reason for the GI bleed, number one. Number two, there is a nice paper that came from Italy. Whoever has undergone endoscopy because GI bleed in COVID-19, most of them seem to be having hepatic-like erosions and ulcer, duodenal ulcer and erosive gastritis, and some of the patients had neoplasm, started bleeding, and malarious tear. And colonoscopy has indicated segmental colitis, hemorrhagic ulcerative colitis, and ischemic colitis is all because of thrombotic dysfunction due to excessive inflammation, hypoperfusion state, direct inflammatory effect on GI mucosa. And it is noteworthy to appreciate here a biliary tree and acute acalculous polycystitis because of the COVID-19 and atypical manifestation presenting as cholangitis, and they have recovered virus from the bile juice. So what does it mean? Virus has entered into the biliary system through the biliary epithelium because they had ACE2 receptors. So emergencies are what common because of COVID-19 itself. And there's a case report on primary biliary cholangitis. And a patient had after the COVID. Now our president was talking about post-COVID. How do you see this? Post-COVID, you can see people with post-COVID cholangiopathy also has been noticed now. So what I want to tell you is not only the biliary system, the pancreatic also can get affected. And the SARS-CoV, the coronavirus 2, that is a COVID-19 virus infection replicates in human endocrine and exocrine pancreas, and it has been associated directly with the pancreatitis. It is very surprising to note that in pseudocyst of pancreas, they have recovered the virus. And what do you do with the pancreas and pancreatitis and COVID-19? Higher rates of organ failure. Now, how did the pancreatitis happen in COVID-19? Because a direct cytopathic effect, a multi-organ dysfunction, and cytokine storm, and mechanical ventilation and hypoxemia, and various drugs being used for COVID-19 now. Now, very important is acute abdomen. My colleagues keep asking me, sir, I have a patient with acute abdomen. My pediatrician particularly asked me, acute abdomen, what is it? I want to refer to the very important paper came in, the impact of COVID-19 pandemic and acute abdominal emergency presentation. This is just a chart to highlight is 2019, we did not have corona, COVID. 2020 we had. And there is definitely number of, even though less number of cases reported to the hospital, but whoever reported, they had a more complication and more required the surgical intervention. This is what I want to impress upon. And this is a picture is be very alarming to see that gangrene of the small intestine. You'll be wondering, COVID-19 so far, we know only respiratory system disease. How did mesenteric ischemia happen? That is because of the hypercoagulability state associated with COVID-19, non-occlusive mesenteric ischemia, arterial and venous microvascular level thrombosis can happen. Some of the drugs can induce, but it is very important to appreciate here is overall mortality in COVID-19 with the GI ischemia is to the tune of almost 1/3 of the patient died. So gastric ischemia has been reported of all GI emergencies around 4%, and a complication, 3/4 of them had complications. Ischemia, hematoma also has been identified because of the anticoagulant usage, and most of them had stormy course. But it's a very interesting observation. Most of the COVID-19 patients have a severe cough, a persistent and violent cough also. That has precipitated certain acute abdomen cases like incarcerated hernia. We did have a patient like that, and perforated sigmoiditis, ulcerated gangrenous perforated appendicitis, and so on. And it's all because of the thrombosis and inflammatory small bowel necrosis. So this is a very dangerous virus. You have to handle him very careful. How dangerous this study will tell you that this study has classified Group A acute surgical condition with a mild or asymptomatic COVID-19, Group A, and Group B, they had severe COVID-19 disease. Mortalities were very high, and the incidence of ARDS, requirement of invasive ventilation also very high with the Group B, meaning that COVID-19 really had a major impact in acute abdomen management. Coming to there are certain pre-existing GI disorder. This is the one we have seen enough cases, several cases in the last 1.5 years, and GI disorder presenting as emergency. What are they? If you have a liver disease that get exacerbated because of the virus and certain drugs use, systemic inflammatory response, and hypoxic injury. Take ALT and AST, that is liver enzymes got elevated. Liver dysfunction associated with the most severe COVID-19. A patient with LFT normal COVID-19, another patient COVID-19 with abnormal LFT, mean that is a severe case of COVID-19. And those obese patients are more vulnerable to the COVID-19. COVID-19 increased the risk of death in cirrhotic. We did have patient and coming with hepatic decompensation, and so it has been now recommended all cirrhotics should undergo RT-PCR and make sure that they do not have COVID disease because they are likely to worsen. And certain drugs can also will be a problematic. It's better to avoid remdesivir and decompensated cirrhosis and transaminase elevation. And beware of reactivation of chronic hepatitis can happen with the liberal dose of a steroid to save a patient of COVID-19. So you have to be very careful when handling liver patient. What about IBD? IBD refers to ulcerative colitis and Crohn's disease. We use a lot of immunosuppressive drugs, so risk of infection is there. And but however, it is recommended to continue the treatment. Don't withdraw the treatment. Only make sure that you wean off the steroid as early as possible, and you can postpone elective endoscopy surveillance. And you you advise them to strictly adhere to the personal protection. This is a very interesting. I just referred to a very internet. Just want to tell you the international paper here. The mimickers. What do you mean mimickers? Everyone came to the hospital with a fever and cough, and they did have upper abdominal pain. They initially thought because of the fever, cough, and everyone had bronchopneumonia, COVID-19. They were negative for COVID-19, but however, they had all these major GI problems. Here, the lung will be confusing as COVID-19. At the same time, you will be perturbed to take up the GI emergencies, but make sure that all pneumonias are not COVID-19, and you have to be very clear about dealing with GI perforation like gastric perforation, intestinal stricture, pancreatic necrosis. Very interesting case of rectosigmoid tumor presenting with the lung metastasis, mimicking like COVID-19 pneumonia. So this is very interesting. Among children, the prevalence is 18%. Many pediatric colleagues, they keep calling me, is there any difference between adult and children? There's a one difference I'll tell you. The symptomatology is pain, abdomen, diarrhea, and vomiting, okay. But there is a thing described as pediatric inflammatory multi-system disease. What do you mean by the multi-system disease? This is called the PIMS, temporarily associated with the COVID-19. And children do present acute appendicitis, mesenteric lymphadenopathy, the pain abdomen. How to differentiate this, the PIMS from the acute appendicitis? We did have problem like that, but frequent clinical monitoring, blood test, and the imaging may be required to differentiate PIMS from the acute abdominal symptom. Coming to the very important topic, sir, you have a GI setup, both endoscopy and endotherapy and surgery. How do you manage this? Is there anything you want to tell us? A lot of surgeons are attending this webinar. There are 51, almost half of the collaborators who observed septic abdominal disease. We did see whatever we got gallbladder disease or appendix, they are come with a very late presentation, perforated appendicitis, severe septic cholecystectomy. This is the one important observation is COVID-19. Why it is happening like that? Even though there is a decrease in number of surgical cases, increase in more septic disease, severe septic disease. That is because of fear of patient coming from COVID-19. This is the reason why we started the telemedicine, teleconsultation. Here they can discuss more liberally before, without coming, before coming to the hospital. But another important is that the critical delay. We have seen, my colleagues will present it. I've never seen colonic obstruction so much in number, and they come because of the critical delay in diagnosis and intervention, and the changes in the hospital logistic and operating room. So many, I think our president has really indicated what are the challenges in right from the resources to the remedies. He has nicely enumerated. And this will have a harmful impact on COVID-19 patients in emergency situation. Coming to the endoscopy, now the things are all over the world. The guidelines are very clear. Don't do endoscopy routinely. You do it only for the emergency. This is what I've been following for the last 1.5 years. Very urgent indication. This is should be in your tabletop. Whoever practicing endoscopy, I'm not going to read everything, but only thing I'll tell you: GA bleed, foreign body, cholangitis, GA perforation. You must do immediately, and it's emergency surgery. Now, how did you make yourself get training? It's not enough for the doctors alone getting trained. You have to train all the person available and intended for this kind of treatment for the COVID-19 patients. You have to develop the certain infrastructure. What do you embed? You need to have the negative pressure room in endoscopy and surgical theater, PPE kit, donning and doffing. I think we have talked enough and more. And the most important is you follow the protocol. And many will forget it, how to dispose of biomedical waste. That is a very important crucial time now. This is just to show that how we are converted. We have to take some innovative steps also. This is the ENT microscope cover. We used it for the endoscopy. You see the 3 holes. One, you can put the mouth guard, and we are doing the endoscopy so that the spillage of the whatever the secretions coming from there, because endoscopy has been indicated as the aerosol, the whatever can be spread can happen, aerosol spread from the endoscopy procedure. This is how it looks, right? And see our young team, how they are dressed up with all the protective gear in the OPD and endoscopy suite and the surgical theater also. Now there are 2 important things before I end my talk. How did you manage COVID positive and COVID negative patients? But both of them presenting a GI perforation. What I understood and learned, I just want to say here, if you have a COVID positive patient, make sure that viral transmission does not happen to you and your medical staff, paramedical, and does not spread to the other patient, number 1. Lung involvement requires oxygen and ventilator support. If you're doing a prolonged upper abdominal surgery, then you're going to have post-operative bronchopneumonia. That will be an additional burden. And particularly when you are using immunosuppressive drugs for the COVID-19. So our take has been substitute a major emergency surgery with a minimal invasive procedure, followed by a major permanent surgery if required once COVID-19 is settled. This is how we have taken it. And we have avoided all the major elective surgery. Now, what do you and how did you manage the negative patients? COVID-19 patient or negative patient also, they do present the GI emergencies, quite a large number. We had an experience. What this whole webinar we have designed is, we are going to present 12 case capsule, 3 in GI bleed, and 3 in pancreatic biliary diseases, and 3 in colonic diseases, 3 in acute abdomen. My colleagues, gastroenterologists, who have a tremendous experience after their degree, have been working along with me for more than 5 to 10 years. They are richly experienced in handling this GI emergency. They are going to tell more about the GI emergencies handling in COVID-19 pandemic. Luckily, most of the patients were GI negative only. I introduce here Dr. Gokul, Dr. Raja Yogesh, Dr. Satyamurthy, and Dr. Sabarinathan, and they're all gastroenterology, my colleagues working at MedIndia Hospital. I welcome our speakers also. With this, I just want to say hello to you for the time being. For the time being, I'll say thank you from MedIndia Hospital. Now, as my pleasant duty to welcome Dr. Gokul, my colleague at MedIndia Hospital, to discuss about the case capsules, hepatobiliary pancreatic disorders.
Good evening, everyone. At the outset, I'd like to thank my chief, Dr. TSC, for having given me this opportunity to present here. Thank you, sir, for the nice introduction you gave about COVID-19 and GI emergencies. My topic is pancreaticobiliary case capsules in COVID-19 pandemic. So this slide would show that all the emergency procedures should not be delayed, which includes cholangitis and palliative biliary obstruction management. And all routine endoscopic procedures has to be postponed if at all possible. This is what the Indian guidelines and the American guidelines would tell us. So straight away going to the case capsules, this is a first case capsule. A 68-year-old lady came with fever, right upper quadrant pain, and dark urine of 3 days, suggestive of cholangitis. She had a pancreatic head cancer, which was unresectable, for which she had a palliative biliary metallic stenting in 2019, followed by chemo-RT. This year in March, she had a cholangitis for which an ERCP was done. There was tumor ingrowth, which was dilated and a plastic stent was deployed. This was elsewhere. When she came to us, she was emaciated, she was jaundiced, and she had a mild conjunctival pallor. Her hemoglobin was low and as bilirubin was elevated, as was the liver enzymes. The RT-PCR for COVID-19 was negative and a CT chest was normal. This is the MRI abdomen which showed mass in the head of pancreas, which was infiltrating the adjacent major blood vessels. You also see the dilated bile duct. Despite being a stent, the plastic and a metal stent inside, it was dilated, indicating obstruction by the tumor overgrowth. On Can you hear me? Yeah. So this patient with cholangitis, the general management included starting of IV antibiotic third generation cephalosporin according to the Tokyo guidelines. And there is also a need to do a specific treatment in the form of biliary drainage. We have three options left in our, the first one is to do an ERCP and do a plastic stent exchange. You see the plastic stent, how it looks like. The second option is to place a metal stent. The metal stent has got a wider diameter compared to the plastic stent. The third option is to do a metallic stenting, but prior to that, we ablate the tumor using radiofrequency ablation. So this is how it is being done. So you see that we cannulate the bile duct. We put in a radiofrequency ablation catheter. We ablate the tumor by means of the RFA catheter. And after that, we use a balloon to clear away all the tumor fragments by doing a balloon trawling. That is how it is done. On the left side, you see the RF ablation catheter, which is used, and this is the RF generator. So this is the actual procedure which we did in our patient. We removed the plastic stent, which we have already deployed. Following stent retrieval, we cannulated the bile duct. You also see a metal stent there. The cholangiogram showed a filling defect in the bile duct, indicating tumor ingrowth and obstruction. This is the RF ablation catheter. You see the catheter has got 4 radio-opaque markers inside. The ablation is being carried out from top to bottom, that is from proximal to the distal end of the bile duct. After ablation, we use a balloon to clear away all the sludge on the tumor ingrowth. You see the ablated tumor tissue is being retrieved outside using a balloon. We did this balloon trawling a couple of times to clear the bile duct till the clear bile started coming out. You see now the bile and the sludge is being delivered by balloon. Following this procedure, we introduce a new metal stent within the previously deployed metal stent. So this is a stent delivery system, and this is how a new stent is being deployed within already existing metallic stent. You see the bile is gushing out. This is a cholangiogram picture. On the left side, you see the tumor ingrowth with a filling defect. On the right side, after the RFA procedure, the lumen has been canalized. The liver function test also shows significant improvement in the liver function test after the RF ablation procedure and stenting. So the carry-home message for this case is radiofrequency ablation of tumor ingrowth is carried out to prevent recurrence and reintervention. This is because more than half of these metal stents, which is placed for purpose, gets occluded after 6 months. And RFA ablation is used as a neoadjuvant therapy for treating such strictures prior to inserting stems. And this RFA also been applied to treat metallic stent occlusion by tumor ingrowth, like what we did in our case. Studies also shown that when we compare metallic stent to metallic stent after RF ablation or following ablation, so it is clearly shown that RF ablation increases the survival. It is an independent factor for predicting the survival following procedure. And this is a systematic review and meta-analysis of more than 9 studies involving 500 patients. RFA is safe and improves stent patency and also associated with improved survival. Going to the next case, a 12-year-old boy had a blunt injury abdomen last year, December. He presented with severe post-traumatic pancreatitis. Following that, he had repeated episodes of pain and poor oral intake. A CT abdomen showed a pseudocyst with splenic vein thrombosis, and he was advised surgery elsewhere. He came to us with pain abdomen and fever of 1 week duration in February this year. On examination, he was having tachycardia and he had a pancreatic position. He had anemia for which he underwent transfusion, elevated C-reactive protein indicating inflammation, low albumin because of malnutrition, and elevated amylase because of ongoing pancreatitis. The RT-PCR for COVID-19 was negative. This is an MRI showing a large pseudocyst measuring almost 16 centimeters and a total of around 800 ml within the peripancreatic region in the body and tail of pancreas, with narrowing of the splenic vein and causing significant compression of the stomach. On the left side for comparison, I put a normal pancreas, how it looks like the MRI. Now for this patient with symptomatic pseudocyst, there are 3 options: endoscopic drainage, surgical drainage, or percutaneous drainage. Studies have shown and the guidelines recommend endoscopic drainage is a primary or the initial therapy for draining such pseudocysts before surgical drainage should be considered. So we did a US guided cystogastrostomy. Endoscopy showed significant luminal compression because of pseudocyst. And what we are planning is an endoscopic ultrasound guided drainage of the pseudocyst. This is how a pseudocyst appears in the US as a hypoechoic lesion. We are making a puncture using a cystotome. The tip has got electrocautery enhanced. After making a puncture transgastrically, we are putting in a wire inside the pseudocyst cavity. And this can be seen by both US and fluoroscopy. After placing the guide wire within the pseudocyst cavity, we have to dilate the tract. Only then we can place a stent. You see on the left side, the fluoroscopy, a balloon is being introduced and a dilatation is being done. And after dilating the tract, we are placing a plastic stent. You see the plastic stent being introduced now. This stent is 10 French in diameter, and it has got double pigtails, that is a pigtail on both ends. And after placing the stent, you see that the pseudocyst contents are gushing out through the opening. This procedure is called cystogastrostomy. And this is the stent which you see on the right side, the blue colored one. This stent is also seen subsequently on endoscopic ultrasound as a tram track. Post-procedure, patient had significant pain relief. He didn't have fever. He tolerated solid diet and he was discharged 2 days later. A follow-up MRI after 3 weeks showed significant resolution of the fluid. The scientific data also showed that the endoscopic drainage is much better. It has got shorter hospital stay, better physical and mental health, and lower cost. And it is a safe and effective method of draining pseudocyst and pancreatic fluid collection in children. Going to the last case, a 49-year-old male patient was admitted with upper abdominal pain, recurrent vomiting, and significant weight loss. And recently, he also developed jaundice. On examination, he was malnourished and icteric. His liver functions are shown here. Elevated bilirubin enzymes, serum sodium was low at admission. After stabilizing this patient, imaging was done. On the left side, you see the CT showing a thickening in the antropyloric region marked with arrows with proximally dilated stomach. On the right side, you see the MRCP showing a narrowing of the distal CBD with proximal biliary dilatation. A PET CT subsequently done showed multiple enlarged lymph nodes and also metastatic lesions in the right first rib, as shown in the right picture. On the left side, you see the metastasis in the left femur. So this patient required only a palliative line of management. An endoscopy was done, showed significant stasis, a growth in the antropyloric region, which was biopsied, and a narrowed duodenum because of infiltration. A biopsy showed poorly differentiated adenocarcinoma. The subsequent management is to palliate the gastric outlet obstruction by placing an enteral stent and palliate biliary obstruction by means of ERCP or a PTBD. This patient had a narrow duodenum, so ERCP was technically not possible, and hence he underwent a percutaneous drainage procedure of the bile duct. You see that during PTBD, a guide wire is introduced across the narrowing, and after putting a wire, we dilate the tract before placing a stent. This is how a tract is being dilated. And contrast injection shows contrast flowing into the duodenum. This is followed by placement of a metallic self-expandable metallic stent, 12 centimeter in length and 10 millimeter in diameter. So after placing a stent, our next job was to palliate the vomiting by means of an enteral stent. You see the growth, antropyloric growth, causing significant luminal narrowing. The pylorus being cannulated with a guide wire. After placing a wire, we are placing a metallic stent across the antropyloric growth. You see that the stent is being deployed now. This is how a stent appears after complete deployment. A picture showing a duodenal metallic stent and a biliary stent after the end of the procedure. This patient did well following the procedure. He could tolerate oral liquids followed by solids, and his liver function also showed significant improvement. And studies have clearly shown that endoscopic modality is much better compared to surgical gastroenterostomy for palliating malignant gastroduodenal obstruction. This is a meta-analysis of 9 studies involving more than 300 patients. Endoscopy is much better, higher clinical success, shorter procedure time, less morbidity, and shorter hospital stay. For palliating jaundice, again, endoscopy has shown to be much better compared to surgical bypass. At least there are 2 randomized trials comparing surgery versus endoscopic stenting. Endoscopy clearly scores over surgery. It is cheaper and provides better quality of life. And when it is associated with fewer treatment-related complications, at least in the early stage. So, ladies and gentlemen, the take-home message is for palliating jaundice, biliary metallic stent is very useful. To avoid re-intervention because of tumor ingrowth, RF ablation is found it's a very helpful tool. All symptomatic pseudocysts need to be drained, and endoscopy is shown to be much better compared to surgery. For palliating malignant gastroduodenal obstruction, enteral stenting is much better compared to surgical gastroenterostomy. Similarly, for palliating jaundice, ERCP and placement of biliary metallic stent is much better compared to surgical bypass. Of course, during the COVID era, we need to do all emergency procedures, endoscopic procedures, avoid elective procedures, do minimally invasive procedures, both endoscopy and surgery, and reduce the need for re-interventions. Thank you very much for your listening. Next, I call upon my colleague, Dr. Rajay Yogesh, for giving his presentation on colonic diseases during the COVID-19 era.
Honorable guest of honor, Dr. Professor Jayalal, respected panelists and other delegates, wish you a very good evening. So I'll be talking on the colon, colonoscopy, and colorectal cancer, how it is affected during the COVID-19 era. So that will be my talk. Excuse me. I hope my slides are visible. So I'll be talking on the colon, colonoscopy and colorectal cancer and how it has been affected during the COVID-19 era. So during the first wave, what was known was that there was viral shedding in the stools, and it was happening as late as 5 weeks after recovery from the initial infection. Then we also knew that diarrhea could be a presenting symptom of COVID-19. So both these factors were probably the reason why there was a restriction. There was a considered as a risk of transmission during colonoscopy, as a result of which there was suspension of screening services, especially endoscopy and colonoscopy. Apart from this, there was also a general apprehension and anxiety from the patient's point of view towards visiting a hospital. So these two things, these four things had a significant impact on GI practice. First, namely the patient's apprehension towards visiting the hospital, as well as screening of endoscopic services. This has resulted in delayed reporting of GI ailments. There has been a significant patients who have reported with advanced inoperable malignancies. And also there has been a general increase in the number of emergencies as compared to what it used to be the previous year. So in a study which was published in Lancet, it is estimated that as high as 2,700 fewer patients were being diagnosed with cancer in UK each week. Of course, we don't have the data in India, how much of less screening and less diagnosis of cancer has happened, but the amount or the number is going to be significantly higher. So what is needed is a balancing of sorts. What we need to balance is that the risk of infection for the patient who's undergoing endoscopy versus the risk of a delayed diagnosis, especially of a serious illness. So we need to balance these two risks and then proceed with the GI practice. So what has been shown in subsequent studies after the first wave is that the risk of contracting COVID-19 through a colonoscopy is quite low. And in fact, it outweighs the risk of a delayed diagnosis of a serious pathology. So with this prelude, let's go to the case scenarios that we will be discussing. Case 1. So this was a 74-year-old lady who presented with a history of 6 months history of altered bowels in the form of small, mushy and mucoid stools associated with excessive straining. Over the past 2 days, she has developed obstipation, and there was significant loss of weight of around 15 kg since the onset of symptoms 6 months back. This case is a fine example of how a patient is reporting late during the COVID-19 pandemic. So on examination, patient was found to be very pale and emaciated. There was pedal edema, there was tachycardia, and BP was also on the borderline. Per abdomen examination revealed a distended abdomen, and the bowel sounds were sluggish. Digital rectal examination revealed a empty rectum. So with this scenario of altered bowels with an acute history of obstipation, large bowel obstruction was what was suspected. So hemoglobin, coming to the lab investigation, she was anemic, she was having hypoalbuminemia, there was also hypokalemia, and there was prerenal azotemia. So after correction of the prerenal azotemia and hypokalemia, patient was taken up for a CT evaluation. And this is what a CT has revealed. There's significant circumferential thickening of the sigmoid colon, and you can see that there's very minimal of contrast which is going past the obstruction on administering a rectal contrast. So we proceeded with the colonoscopy. Here you have the lesion, which is almost a circumferential, totally occluding lesion over here, just beyond the rectosigmoid junction. So we are dealing here with a malignant colonic obstruction. Coming to malignant colonic obstruction, acute colonic obstruction is caused predominantly by colorectal cancer. Nearly 85% of patients with acute colonic obstruction have an underlying colorectal cancer. 15 to 20% of patients of colorectal cancer actually present with an obstruction at diagnosis. Because of this acute obstruction, usually patients report in a very moribund condition with tachycardia and features suggestive of advanced sepsis. So what are the treatment options that we have over here? We can consider an emergency surgery. And we can also have an endoscopic option. When coming to the endoscopic emergency surgery, the risk factors here are that the patient already has a very poor general condition. There's hypoalbuminemia, there's anemia. And on this background, when we proceed with an emergency surgery, it usually carries a high morbidity and mortality. And very often it also will involve a colostomy. And studies have shown that a colostomy done in an emergency setting, most often 40% continue to have a permanent colostomy. Next, we have the endoscopic option. Let us discuss what are the endoscopic options at hand. So the endoscopic option for the palliation of or treatment of a colonic obstruction is predominantly a self-expanding metal stenting. So this is a short video explaining what a short self-expanding metal stent is. Here the guide wire is passed across the obstruction and the delivery system is passed. And here you see the self-expanding metal stent, how it's expanding and creating a lumen and now relieving the colonic obstruction. So there are two ways in which SEMS can be deployed in a patient with colonic obstruction. One is as a bridged therapy. Here, for example, a patient is presenting with an acute colonic obstruction. Then instead of taking up for an emergency surgery, you deploy a SEMS as a bridging therapy and then take up the patient later on as an elective patient where you resect the tumor. So this acts as a bridge therapy in a patient who is operable. The second means of deploying a stent is for a patient with a very advanced malignancy where it's already metastasized. There you deploy a stent purely as a palliative mode of management. So what are the benefits of doing a stenting and then taking up a surgery later on is that you have time for the stabilization of the patient. You have time for optimization. So all the other parameters like anemia, hypoalbuminemia, dyselectrolytemia, respiratory embarrassment, everything can be improved upon. Nutrition can be improved. You can also do a proper staging of the disease so that you can plan the resection. And in case we are considering a neoadjuvant therapy, for example, a higher rectal lesion, neoadjuvant therapy can be planned. And also there is a chance of reduction in the chance of colostomy. So in other words, you're converting an emergency surgery into a planned elective surgery. And this has definitely shown to have a better outcome. At present, this bridge therapy where you deploy a SEMS and then take up for an elective surgery is indicated in patients who are greater than 70 years. Mind you, these are all operable patients. If they are greater than 70 years and have a poor ASA class, then these patients are the ones who will benefit from this kind of a bridge therapy. Coming back to our patient was already moribund, patient was having a very borderline vitals, was having hypoalbuminemia. So this is the mode of treatment that we did for this patient. So coming to the SEMS procedure of our patient, here you can see the totally occluding tumor. The guide wire is passed across the occluding lumen. Here you can see the contrast which is being injected. And then the stent delivery system is advanced past the obstruction. Here you can see that the stent is expanding as we are releasing the delivery system. Here you can see the fully expanded stent. And you can see that already there has been effluent which has been draining out. So this is the fluoroscopic picture where you can see the waste which is happening in the middle of the stent. So after the deployment of the SEMS, the acute obstruction was relieved. Patient was stabilized, optimized with PRBC transfusions. Hypoalbuminemia was corrected. Patient was given respiratory physiotherapy, incentive spirometry. Nutrition was improved upon. And patient was taken up for sigmoid colectomy 8 days later. And the post-op period in this patient was uneventful. Coming to the second case, we had a 67-year-old male patient who was a known cardiac patient, CAD patient, status post CABG and bronchial asthma also. He presented with an acute left lower quadrant pain of 5 days duration. There was also altered bowels in the form of increased stool frequency, frequent urge to defecate, and effective fractionated defecation was also there. He also reported a history of low-grade fever over the past 3 days. On examination, patient was febrile, having tachycardia, and there was severe tenderness in the left lower quadrant associated with a mild form of guarding. Bowel sounds were well heard. So obviously, we are dealing with an acute abdomen here centered on the left lower quadrant. So we proceeded with the blood investigations and CT abdomen. Blood investigation showed an inflammatory state with elevated total leukocyte count. CRP also was significantly elevated. And this is what the CT revealed. Here you can see that there is an eccentric wall thickening of the sigmoid colon. And there is also pericolonic fat stranding that we can observe over here. both in this picture as well as in this picture. So what we deal here is a patient having acute diverticulosis, acute diverticulitis. So acute diverticulitis happens in 5% of patients with diverticulosis. It presents with a triad of abdominal pain, fever, and elevated inflammatory parameters. So the pathogenesis of diverticulitis is that there is generally stasis or obstruction within the diverticulum, which results in increased proliferation of the microbiota within the obstructed diverticulum. This results in local tissue ischemia, resulting in microperforation. So microperforation is the one which lies behind all cases of acute diverticulitis. And this microperforation leads on to further inflammation and infection. So coming to the treatment aspects, what are the treatment modalities that we have for a patient with acute diverticulitis? First is antibiotic, which is the mainstay of treatment. Of course, there has to be a diet modification. Patient has to be on a liquid diet, and in severe cases, patient has to be kept on nilperoral. Then comes to the pain management. There's an option of drainage, percutaneous, ultrasound guided, or a CT guided drainage might be useful, and patient may also require surgery. When we have all these treatment options, what treatment for which patient is what we have to be knowing. So this is defined by the modified Hinchey's classification of acute diverticulitis. You have the stage 0 and stage 1A, in which the inflammation or the problem lies within the colonic wall or just adjacent to the colonic wall. At the maximum, what you have is a pericolonic fat stranding. Next, you have the stage 1B, in which there is a pericolonic abscess. Here you can see just adjacent to the colon, there is an abscess which is there. And then we have the stage 2, in which there is a large intra-abdominal, pelvic, or a retroperitoneal abscess. This is a significantly larger abscess distant from the colonic tissue. Then we have the third class or third grade, in which there is generalized purulent peritonitis. There is no fecal material or fecal material which is drainage from the colon, but just a lot of pus which is released into the peritoneum. There is no free communication between the peritoneum and the colonic wall here. And the last and the most severe stage is the generalized fecal peritonitis, in which there is a through and through perforation of the colon, by which the fecal contamination happens into the peritoneum. So in this stage 0 and stage 1A, a conservative line of management usually will suffice. So antibiotics, pain management, and diet is what is required. Stage 1B and stage 2, here is where there is an abscess or a large phlegmon. Here's when an image-guided drainage would be required. And stage 3 and 4 is where surgery, most commonly a Hartmann's procedure is performed. If the patient's general condition is very good, we can also do a primary reconstruction surgery. So coming back to our patient, what we have here is only a pericolonic fat stranding and a thickening of the colonic wall. So the patient falls under a stage 1A. So here, being a stage 1A, a conservative line of management is what was indicated. So a patient was kept on oral liquid diet and started on antibiotics, piperacillin, tazobactam, and metronidazole, and also with a smooth muscle relaxant for the colon. Mebevirin was given. So the course during the hospitalization, fever and tachycardia reduced by the day 3. The patient was discharged on day 5 on oral antibiotics. In patients with diverticulitis, what is important is that all patients would require an interval colonoscopy 4 to 6 weeks later, so that we don't miss out on any stricture. There could be a concomitant malignancy in these patients, and also complications like segmental colitis or fistula also needs to be ruled out. Coming to the third case, we have here a 47-year-old male patient who presented with diffuse abdominal pain, bloating, and distension of 15 days duration, which had worsened for the past 3 days. There was a significant difficulty in passing flatus and stools, for which he had to strain excessively. And there was also fractionated bowel evacuation, in which he had to empty his bowels over multiple episodes throughout the day. There was no history of any blood in the stools, and there was no history of any recent weight loss. There was a significant past history in the form of patient having had a rectosigmoid growth, a moderately differentiated adenocarcinoma, for which he had undergone a low anterior resection 4 months back, and after which he had lost all follow-up. This is another patient, because of COVID scenario, who had lost follow-up and ultimately landed in an emergency here. On examination, patient was fair. General condition was fair. Peritoneal examination revealed a distended abdomen. There was no mass which was palpable, no free fluid, and bowel sounds were heard. So because of this abdominal distension with a recent history of rectosigmoid malignancy, the first clinical impression was to rule out a colonic obstruction, possibly secondary to a recurrent growth. So we proceeded with the CT abdomen. CT abdomen revealed a focal thickening at the anastomatic region at the rectosigmoid with luminal narrowing. So the things which were considered following a CT was definitely an obstruction, which could be an anastomotic stricture or even a recurrence. So we proceeded with colonoscopy. Here it was very surprising to see that there was absolutely no lumen that we could find out. Here you can see the surgical staples around, and this is the tiny lumen. And it was a surprise for us how this patient has been managing to pass even the little amount of stools that he was saying to have passed in the past few days. So there's almost total luminal occlusion in this patient. So coming to the management of anastomotic strictures, we have endoscopic option as well as we have surgical options. Coming to the endoscopic options, you have most commonly or most popular what is done is a CRE balloon dilatation. Stricturoplasty using electrocautery or laser also has been attempted. There has been conditions where recurrent strictures have been treated with local steroid injections, and stenting also has been attempted in recalcitrant patients. When it comes to surgery, this would usually involve a surgical resection and a reanastomosis. Being the COVID era, we opted for a minimally invasive management in the form of an endoscopic therapy. So what we used in this patient is a CRE balloon dilatation. So what does CRE stand for? Controlled radial expansion. Here you can see that the balloon is passed across the stricture and variably expanded so that the stricture is dilated. Coming to the dilatation of our patient, here the guide wire is passed across the stricture. And then here you have the CRE balloon, which is passed across the stricture, traversed the stricture, and then distended. One advantage of a CRE balloon is that it's a transparent balloon. So by which you can see through the balloon and you can actually visualize the stricture for any proliferative elements. And after dilatation, you can even just do a gentle push by which you can traverse the stricture while keeping the balloon inflated. This is exactly what we've done. And here, while withdrawing, we can see that there is a proliferative element in the stricture as well, which has been biopsied. So luckily for the patient, the biopsy revealed only granulation tissue. There wasn't any evidence of recurrence, though we can see some proliferative element in the stricture as well. So post-procedure, patient reported good relief, and patient was able to pass stools without any discomfort. There was recurrence of symptoms after 2 months, requiring a second session of dilatation, after which patient has been asymptomatic since. So to conclude the presentation, so there has been generalized infection phobia for patients because of which there is a general hesitancy towards having a proper consultation. This can be considered as a COVID-19 barrier, or more appropriately, COVID-19 healthcare barrier. They are averse to having a health consultation, because of which there has been a general malignancies which have been diagnosed at an advanced stage. There has been an increase in number of emergencies, and also a number of complications because of neglected symptoms have been come about. So what we need is to outweigh the risk of infection versus the risk of delayed diagnosis. And the risk of colonoscopic transmission being deemed low, there is a general tendency worldwide to have a resumption of screening services, especially when it is feasible or when the patient is having an alarm symptom. And always in the COVID era, whenever feasible, a less invasive treatment option, because there is going to be a reduction in the manpower and a reduction in the logistics. So a less invasive treatment option would be a prudent choice. Thank you very much for your patient listening. Next, I call upon my next speaker, Dr. Satyamurthy. He would be delivering on the GI emergency, which is GI bleed. So over to Dr. Satyamurthy.
Very good evening to one and all. At the outset, I would like to thank my chief and mentor, Dr. TSC sir, for giving me the opportunity to present 3 case capsules on the GI bleed, which we managed during this COVID-19 pandemic. So GI bleeding is one of the most frequent emergencies we encounter in our GI practice during COVID and also the non-COVID era. The prevalence of GI bleed among the COVID-19 hospitalized patient was estimated in various studies to be between 4% to 13.7%. In this COVID era, we see a rapid decline in the non-varicose type of upper GI bleeds up to the tune of 50%. And there are no change in the incidence of varicose bleeding during the COVID era. So among the patients with GI bleed admitted during the pandemic period, the GI bleed events are considered as more severe events, and the outcomes were very poorer than compared with the prior to the pandemic situations. So I am here to present 3 interesting case capsules of GI bleed what we managed during this pandemic period. Going to the case number 1, an 8-year-old female who was a known hypertensive patient and a cardiac patient was on antiplatelet therapy. And she's also a known IBD patient, ulcerative pancolitis, which is in remission on maintenance oral mesalamine therapies. She presented to the emergency department with a history of recurrent bleeding per rectum for the past 4 days, which was intermittent, small to large volume, fresh bleeding per rectum, associated with generalized weakness. Next is not good. On examination, she was severely pallor and showed signs of peripheral edema. Her BP was stable with 110/70, and investigation showed a low hemoglobin 6.4 gram and hypoalbuminemia 2.8 with an elevated CRP. RT-PCR for COVID-19 was negative. So she had an LGA bleed, possible source in view of an underlying IBD, possibly it could be an IBD related or an perianal lesions in elderly. So since she was hemodynamically stable, we proceeded with a full-length colonoscopy after a complete bowel preparation. So the IBD features were very quiescent, which were, and we noted multiple diverticula involving the sigmoid descending colon and also the right side of the colon, ascending colon. So this is the colonoscopic view on the right side of the colon, that is in the ascending colon. We noted acute active bleeding from one of the diverticuli. So it's a case of colonic diverticular bleeding precipitated by taking an NSAID and a clopidogrel intake. Most common cause of an acute lower GI bleed is that colonic diverticular bleed in 1/3 of the patients. Though the diverticular disease are more common on the left side, the diverticular on the right side of the colon are more likely to bleed because of their wide mouth and increased chemical and mechanical trauma to the right side of the colon. And though 80% of these bleeds are conservatively managed, 20% up to 1/5 of the patient needs a therapeutic intervention. How this bleeding happens is repeated microtrauma and thinning of the already thinned out diverticular sac, especially near the neck and fundus of the diverticula, causes the penetrating vessels to have a segmental weakness of the vasa recta, and thus bleeding is precipitated. So other risk factors can precipitate the diverticular bleeding is an elderly age, smoking, alcohol consumption, and associated atherosclerotic disease. It is in various studies found that more than 3 comorbid conditions can precipitate diverticular bleed in the elderly, and the intake of certain drugs like steroids, NSAIDs, and the antiplatelet drugs can precipitate a diverticular bleeding. What are the management options for a diverticular bleed? Resistation followed by diagnostic colonoscopy is recommended first line of investigation. We can identify the source of bleed and the signs of recent hemorrhages, and we can plan an endoscopic treatment when it is not amenable for endoscopic therapy. Then an interventional interventional radiological treatment in the form of an active CT angiography revealing any acute bleeding, and selective angioembolization of the bleeding vessels can be done. And if it is not controlled with the interventional radiological procedures, then a surgery, it could be a partial colectomy or a subtotal colectomy in cases of failed endoscopic or angiographic interventions. So what are the treatment endoscopic options in diverticular bleed? We have two techniques like clipping technique and banding technique. The clipping technique can be a direct technique or an indirect technique. If we are able to visualize the culprit vessel within the diverticular sac, then it can do a direct hemoclipping endoscopically. It's called the direct hemoclipping technique. The other technique is just to close the diverticular orifice by using multiple hemoclips, which is called the reefing technique. Then there is another technique of banding, just like we do it for varicose bleeding. So the band loaded endoscope is targeted near the diverticular bleed. Suck the diverticulum to cause an inversion of the diverticular sac and put a band after the readout sign that will arrest the bleeding there. So what we did for this patient is a clipping technique. The exact vessel, a bleeding vessel could not be identified. So there was a diffuse bleeding from the diverticulum. So we did multiple hemoclips to close the diverticular orifice, which is called the reefing technique. Use the hemoclip application to stop a diverticular bleed. After that, the patient became stable and there was no further bleed, and she was discharged. So coming to the second case, is a 32-year-old man who had visited us with 3 months history of progressive jaundice, intense pruritus and fatigue, and occasional fever with high-grade fever with chills and rigor. On examination, he was deeply tricked. There were no signs of hepatic decompensation except for a moderate splenomegaly on examination. So his investigation showed an elevated total leukocyte count indicating sepsis with a high total bilirubin with a predominant direct fraction indicating an obstructive type of jaundice. His albumin was normal. He had an MRI and MRCP with him, which showed an choledocholithiasis in the floating mid-CBD calculus with a diffuse narrowing of the distal CBD for a length of 2 centimeter and features of chronic portomesenteric thrombosis with multiple collaterals and moderate splenomegaly, a diagnosis of extrahepatic portal venous obstruction with possibility of a portal biliopathy was noted. This is the MRCP and MRI picture showing the distal CBD could not be clearly visualized, and there is a suspicious stone in the distal CBD with the dilated intraoperative biliary radicals. So this schematic picture gives an idea about what is portal biliopathy. The presence of biliary tract abnormalities in patients with extrahepatic portal vein obstruction, portal cavernoma. What is happening here is the portal vein is completely replaced with multiple collaterals around the bile duct, and it is the paracholedochal veins and the epicholedochal veins which engorge due to the portal pressure, which compresses the bile duct and causes strictures, and subsequently due to the obstruction, biliary tract obstruction, the stones are formed. So we proceeded with an endoscopy in this patient, which showed a large esophageal varices and features of portal hypertension and portal hypertensive gastropathy. Ampulla appeared normal. Since he presented with us with cholangitis, he was taken up for an ERCP procedure, and to relieve his obstruction, we did an ERCP in this patient. So after cannulation of the bile duct with a sphincterotome, a minimal sphincterotomy was done, following which a balloon catheter was introduced for stone extraction. So this is the video. During stone extraction, a lot of muck or sludge came out from the CBD, and the stone got delivered. And following which, repeated balloon trolling to clear the CBD done. And to our surprise, we noted this torrential bleeding from within the CBD. It almost filled the entire lumen of the duodenum, and the visualization and further procedures was hindered. So what could be done now? What are the options now to stop this bleeding? So it's a case of portal biliopathy and hemophilia. So he was started on somatostatin analogs to reduce the portal pressure. Whether we can do an emergency tips as an interventional radiological procedures. The patient is already on table, he's bleeding, but that is not possible in this case. Or shunt surgery is a possibility, but immediate surgical consents, and this was very difficult during this COVID era. Is there any possibility of doing an endoscopic intervention this patient to save his life with this torrential bleeding? Yeah, we have an option of fully covered self-expanding metallic stent. This has saved us, saved this patient also, and saved the endoscopist also. So we have an already the cannulated, guide wire in situ. So over the guide wire, we just introduce this fully covered metal stent through the, and we have placed this fully covered stent. So it slowly expands and compresses the entire CBD, and the bleeding has arrested. So coming to the third case, this is a 77-year-old gentleman who was recently diagnosed elsewhere with a cryptogenic decompensated cirrhosis in December 2020. He presented to the emergency department with multiple episodes of fresh blood vomiting, around 200-250 ml, and recurrent melena. On examination, he was pallor, icteric, and showed signs of decompensation, bilateral pedal edema. BP was on the lower side, and he had a moderate ascites. Lab parameters showed low hemoglobin of 7.2 and low albumin of 2.5 and INR of 1.87, coagulopathy. So we stabilized the patient. RT was inserted. RT showed a fresh blood, and PRBC transfusion was arranged, and somatostatin was infusion was started in view of portal hypertensive bleed, and to correct the coagulopathy, vitamin K and plasma were ordered and started on prophylactic antibiotic. This is the OGD showing an active bleeding and collection of blood in the fundus. So on further inflation of the stomach in the retroflex showed the actively bleeding large gastric varix. The torrential bleeding and the bleeding spot is there. And so it's very difficult for us because it's directly bleeding onto the lens of the endoscope. So it's a technical challenge we faced. So if you see the gastric varices, up to 1/5 of the patients with portal hypertension develop the gastric varices, and it is the source of bleeding in about 1/3 of the patient in all varicose hemorrhages taken. Though they bleed less often, but the bleeding is very heavy, requiring more number of transfusions than compared to the esophageal bleeding. And if the incidence of rebleeding rates is also very high if we are not tackling it in the so these are types of gastric varices. There are 4 types of gastric varices: type 1, type 2, type 3. Isolated gastric varices type 1, isolated gastric varices type 2, and gastroesophageal varix 1 and 2. So among the various etiologies of gastric varices, cirrhosis, non-cirrhotic portal fibrosis, EHPO, it is the extrahepatic portal venous obstruction where the gastric varices are more common, and those are the varices which are likely to bleed also. So the other risk factors for gastric variceal hemorrhage is not only in the location of the gastric varix, it's the size. Larger the varix, the more prone for bleeding, and the higher the grade of liver disease like CTP class C and MELD more than 17, they are more likely to have a gastric variceal hemorrhage. And the patients who are already developed hepatocellular carcinoma are at increased risk of gastric variceal hemorrhage. So what are the treatment modalities available? It is proven that glue therapy to obliterate the varix by solidification by injecting the glue into the directly varix has been the treatment of choice. Now in the era of endoscopic ultrasonography, US guided therapies are also coming up. Then if endoscopic modalities cannot obliterate the varix, then interventional radiological procedures like tips and balloon retrograde occlusions can also help as a bridging therapy before a liver transplant and or surgical interventions. So what is basically this glue therapy? Glue is coming as a monomer solution which is this is an in vitro picture showing how a glue rapidly polymerizes and get solidified when it come in contact with the blood. So we need to inject this monomer glue solution through an injection catheter into the varix, so to precipitate or to have a solidification of the varix to prevent the bleeding. So this is what we have done in this patient. So it's actively bleeding. So through an injection catheter, 23 gauge sclerotherapy needle, we are going to inject the glue directly at the site of the bleed. So after the injection, it should be a rapid action coordinated with the staffs. So multiple injections can be given until the varix get obliterated. So GA bleed is the most common GA emergency during COVID pandemic. Although the endoscopic techniques and the tools of GA bleed management are the same, we had many challenges in during this pandemic era, like reduced availability of blood and blood-related products, and modification of the endoscope suite, maintaining a negative pressure room, and aggressive disinfection protocols. And we need to work with the minimal staffs, helping hands, and adequate protection should be made by giving an enhanced PP kit. So life-saving endoscopic procedures are never halted even during the pandemics. We continued our emergency services. And a big salute to all the corona warriors who had immensely contributed and saved many lives in this. So one more underlying point is safeguard first, safeguard yourself, and can save others. Thank you for giving me this opportunity to present. With this, I hand over. And I'll call upon the next speaker, my colleague, Dr. Sabrinathan, to speak on acute abdomen management during COVID-19.
Respected teachers, senior professors, and my colleagues and friends, respected teachers, senior professors, colleagues, and my friends. Good evening, everyone. I am here to present 3 interesting cases on acute abdomen. So let us see the first case. Our first case is a 48 years old female patient. She is a known case of diabetes, hypertension. She is morbidly obese and had a bilateral chronic venous insufficiency for a longer duration of time. Also, she had a cryptogenic chronic liver disease of child-based status with underlying hypothyroidism, and she also had asymptomatic cholelithiasis. She presented to us with the sudden onset of severe epigastric pain associated with vomiting of 3 days duration. On admission, she had tachycardia, abdomen found to be distended. It was tender on palpation and rigid with obliterated liver dullness on percussion, and scanty bowel sounds were there. Chest X-ray revealed a bilateral air under the diaphragm. Labs revealed lower hemoglobin of about 7.5 grams, and she also had leukocytosis and prolongation of INR due to the underlying chronic liver disease. The COVID-19 RT-PCR was found to be negative. So we proceeded with the CT abdomen. The CT abdomen revealed a pneumoperitoneum with a mild to moderate ascites, and also there was a suspicion of a perforation in the duodenum. So we stabilized the patient with Nilper oral, and Rayleigh tube was placed, and IV fluids were started, and the antibiotics were started. Since he had a low hemoglobin, we need to transfuse blood in the form of packed red blood cells, and also we need to correct coagulopathy. But the challenging point in this case, in the COVID era, even getting a blood products is a difficult task at present, because donors, they are not coming to the lab to donate the blood with the anxiety of getting COVID infection. So after stabilizing the patient, patient was taken up for the surgery. So this is the illustration clearly showing about the intraoperative procedure and findings. The patient was, after opening the abdomen, there was a turbid bile stain fluid was there. It was clear, and the viscera was examined, and there was a perforation was noticed in the duodenum, and the routine 3-tier Lambert suture were applied in the duodenum to close the perforation. So following which the omentum was mobilized, and the omental patch was applied, and it was closed, and drains were applied. The post-operative course, patient was adequately hydrated and continued higher IV antibiotics. But the challenge faced in this case, patient also had lower respiratory tract infection. It was masquerading as a COVID-19 pneumonia during the post-operative period. So we repeated the reverse RT-PCR test for SARS-CoV-2, but it was negative. But we subsequently submitted her for CT chest. CT chest revealed consolidation findings in the upper and middle lobe, and also in the basal segments, predominantly in the right side. But it was not mimicking as a COVID-19. So this is a post-operative pneumonia, which is common in patients with a lot of comorbidities. Particularly, this patient had a chronic liver disease. Patient was morbidly obese and also had chronic venous insufficiency for a longer duration. However, she improved with the supportive measures, and she was discharged in a stable condition after 8 days of hospitalization. So coming to the case capsule 2, she is a 57-year-old female patient with underlying hypothyroidism. Patient underwent total hysterectomy with a bilateral salpingo-oophorectomy, following which she underwent a radiation therapy for carcinoma of cervix 6 years ago. And she had a recurrent abdominal pain associated with abdominal distension and vomiting for 6 to 8 months. But she never turned up to the hospital because she also had the anxiety of acquiring COVID-19 infection. And she somehow tolerated the pain. And but subsequently, patient developed severe diffuse abdominal pain of 3 days duration, and she could not able to pass stool and flatus for 1 day. So at the time of admission, patient was found to have tachycardia, abdomen was found to be distended. There was tense diffuse tenderness, and bowel sounds were absent. Labs revealed leukocytosis with a highly elevated CRP count. Chest X-ray revealed pneumoperitoneum noted under the right side of the hemidiaphragm, and the lung fields were clear. And the X-ray abdomen revealed a few air-filled bowel lobes. So with this background, patient was submitted for CT abdomen. CT abdomen revealing the thickening in the terminal ileum
but the ileal loops were found to be in the suprapubic region, surprisingly, and it was some adhesions were also noted. At the site of narrowing, there was a small bowel feces sign suggestive of possible perforation in the ileal loop. So proximal to the narrowing, small bowel loops were found to be distended, and also you can clearly see the pneumoperitoneum. Patient was stabilized with routine measures, NPO, Rails tube, IV fluids, and higher IV antibiotics. He also had hypotension due to sepsis, but it was stabilized with vasopressors. So after stabilizing the patients, we proceeded for a laparotomy. So this is the illustration showing the findings during the procedure. You can see the turbid fluid in the peritoneal cavity, which was cleared, and the small bowel loops were found to be dilated. And also you can see the ileal loops were adherent to the sigmoid colon, particularly in the left iliac fossa. We can notice the lot of adhesions, and the entire pelvis was appeared to be frozen. It was a lot of adhesions. The point to be noted here is the patient had symptoms for a longer duration, about 6 to 8 months, but she ignored the symptoms and ended up with complications like a progression of adhesions, ileal narrowing, perforation, and other things. So the entire small bowel loops were found to be dilated. It was so much friable, and a lot of flaky materials were noted in the wall of the small intestine. And also it was very difficult task to remove all the adhesions. But however, we identified the ileal perforation, we closed it first. But mobilizing the ileal loop proximal to the perforation, it was a very, very difficult task. So hence we plan to proceed for the proceed to decompress by ileostomy measures. So we planned for a loop ileostomy. That was also difficult. Hence we have completed as a end ileostomy. Proximally you can see the end ileostomy, and distal to that you can see the mucus fistula. Drains were fixed. During the post-operative period, the sepsis controlled with the higher IV antibiotics, and she improved gradually. She tolerated oral feeds and discharged after 13 days of hospitalization. So coming to the final case, capsule 3, he is a 25-year-old young patient. He had a pain in the right lower abdomen of 7 days duration. It was intermittent, colicky, and moderate intensity, and it was not radiating. On examination, there was a tenderness in right iliac fossa, and there was no mass felt. Labs revealed elevated C-reactive protein. We submitted the patient for contrast-enhanced CT abdomen with the oral contrast study. During the oral contrast study, we noticed there was a diffuse circumferential narrowing in the terminal ileum, ileocecal junction, and also involving the cecum and the base of the appendix, and there was periserosal fat stranding was also noticed. So proximal to which small bowel loops were appeared to be distended. So it was reported as a subacute intestinal obstruction, possibly due to tuberculosis or Crohn's disease. Next, we prepared the patient with a bowel preparation. So after the bowel preparation, patient was submitted for colonoscopy. You can see the nodularity and the thickening and the induration in the ileocecal junction. And we could not be able to separately see the ileocecal wall. So we have taken multiple biopsies from the lesion. So this is the histopathological examination. You can see the classical granuloma in this picture. Patient was also underwent Mantoux test. So Mantoux was found to be positive, very, very strongly positive. So, so with this, patient was diagnosed as a intestinal tuberculosis. So we started the patient on ATT, and we are following the case, and he is doing well. Initially, we thought patient may require surgery, but it was diagnosed as ileocecal tuberculosis, now responding to the ATT well. So coming to my last part of my presentation. So every coin has two sides. Now we are giving more attention to the COVID-19 situation. But on the other hand, the COVID-19 made a catastrophic damage in the non-COVID patients also. So we have to tackle that issue also. So patient developed a lot of anxieties. So they are coming to the hospital very late, and they are it's ending up with a lot of complications. So to conclude, delayed presentations leads into complications. Patients need to be educated to continue to present to hospital services at the earliest. This is very, very important in this present scenario. And they should be informed of the measures in place throughout the healthcare institution to keep them safe from the spread of the virus. So thank you. And now I will request our Chief Dr. TSC sir to take over and conduct the further proceedings.
I think I thoroughly enjoyed the wonderful webinar. It showed a great team effort. One after the another speaker passing the baton from one to other, telling the 4 different areas of GI emergencies. It is heartening to see this, and in a difficult time of COVID-19, we have been able to manage GI emergencies as a team effort. What is important is all the speakers, they had a nice exposition of the cases with a lucid explanation, revealing their rich experience. And the more important, the 3 things had emerged from this talk. One is there is a fear complex among our patients visiting the hospital. So there is delay in diagnosis. Definitely that you cannot deny this fact. Number 2, there is a mimicus. All pneumonia they consider as COVID pneumonia, either delaying the surgery or postponing the surgery. Third thing is availability of the resources, both medical and paramedical. As the speaker, Dr. Sabari, put it correctly, in the managing COVID-19, we should not miss the patient, non-COVID patients requiring emergency surgical intervention or endoscopy intervention. And doing a prolonged surgery may be detrimental to the patient. So we need to innovate ourselves with the minimally invasive procedure so that you can buy time and do it. These are the few, the consensus I could make out that what we have to learn from this COVID-19. This is very important when the scientists, some of them are telling that maybe a 3rd wave also, particularly in the pediatric age group. So we have to gear up ourselves managing such situation. All the speakers, they did a wonderful job explaining in detail hepatobiliary pancreatic, number 1, and by Dr. Gokul. And number 2, the colonic obstruction, very surprising. I will tell you that colonic obstruction in non-COVID time, we hardly ever see. They come very early, but here we have seen almost 3-4 cases in a year time. That is the very thing I just want to tell you here. And we had to really manage that with the colonic stenting and balloon dilatation, etc. And it was nicely dealt by Dr. Raja Yogesh. And the 3rd speaker, GI bleed. GI bleed is very alarming, and he managed it quite a bit. We have several questions in the chat box, almost as many as 35 questions, let's say. She will take up some important questions, and many on GI bleed too also. And it was nicely discussed by Dr. Satyamurthy. And the last speaker, I was wondering whether it's a surgeon also, because he was nicely showed the schematic diagram of the duodenal ulcer perforation, ileal perforation, and so on. And lastly, he showed a coin. I wish that coin instead of 2013 had 2009-20. So that was the COVID time. But I don't think coins are printed in the year 2020, but he had to be satisfied with 2013 coin. So now coming to the panel discussion, first I wanted to, we have a very experienced surgeon, Dr. Ramakrishnan from Trichy. He is currently the president of Tamil Nadu IMA. Sir, how it has shattered your kind of the approach? I mean, the sense, suddenly you are seeing COVID-19 and GA emergencies. So we have to have the full of wisdom from you, having practiced over 3 decades. And I know that your son is a surgical gastroenterologist too.
Yes, sir.
So you would have come across a lot of GA emergencies. So we like you to share your experience with us. That would benefit our delegates. Can
Very
you
good.
unmute yourself, sir?
Yes, sir. Unmuted.
Yeah.
Very good evening to everybody. At the outset, I would like to thank Dr. T.C. Chandrasekhar, Chairman and Chief Interventional Gastroenterologist, organizing this good program today under the auspices of MedIndia Academy Hospital, Tamil Nadu Medical Council, MGR Medical University, and Indian Medical Association, and for inviting me to be part of this function. I would like to say a few words about our IMA and our activity with the government in maintaining the COVID pandemic. IMA is the largest body in the world with 3,75,000 members, and the Tamil Nadu State Branch has got about 37,000 members with 4,495 hospitals with 165 branches, and we have got a bed strength of about 76,857, oxygen beds 23,000, and ICU beds 82,000. Tamil Nadu has a seamless system of managing the pandemic. Once samples are lifted and processed, results are conveyed to the patient, corporation, health department, and also to the police. Corporation people, they pick up the patient and they bring the patient to the specified fever clinic where they undergo further investigations. And based on these investigations, we segregate the patient for either home isolation or hospitalization in COVID care center with higher symptoms and with very bad symptoms. We send them to COVID hospital, and ultimately we send them to higher hospital for further management. Tamil Nadu is the only state using RT-PCR for diagnosing COVID, and every day Tamil Nadu government is doing about 1,78,000 RT-PCR tests, which is the highest in our country. And so far, we have done about 2,81 lakhs RT-PCR tests. This, we are the forerunner in, in the whole of our country. To control COVID pandemic, 3 important factors must be there. 1, vaccination. 2, people's behavior. Unless people cooperate with us, I don't think we will be able to contain the pandemic. And 4, viral mutations. And during this second wave, after lockdown, we find more more important findings. See, in whole of Tamil Nadu, on 24th, there were daily cases of 34,000. Now it has come to 22,000 per day. And the deaths, they remain the same. And in Chennai, we had about 7,500 cases. Now it has come down to 2,200 cases. And the treated cases, they exceed more than the admitted cases, and the workload has come down. And the R0 value, test positivity rate, case fatality rate, they all have come down. The doubling time has been increased. In this scenario, total daily cases and daily deaths curve will flatten in short duration. I wish today's program, COVID-19, gastrointestinal emergencies and challenges and solutions, and panel discussion with the eminent speakers from your institute. We had a very, very good talk, very good presentation. We learned very many things. I wish all the program all success. Thank you very much again for inviting me to part of this.
Sir, Professor Ramakrishnan, thanks for compliment the same time. Laudable efforts of Tamil Nadu. It is heartening to know that 2 crores RT-PCR has been done every day, and nice to know that over 2 lakhs people being screened with RT-PCR, that the highest in the country, and how IMA has been very supportive for this cause. But well said, unless people behavior changes, whatever may be our efforts, will not bring out 100% success. This is a message we will carry forward. I think we'll communicate. Those who are all watching the delegates, each delegate will carry the message to thousands of people, not only the medical fraternity, through medical fraternity to the common man. We make at the earliest Tamil Nadu safe, and we start progressing better towards non-corona activity, the sense for economic and medical activity. And thanks for sharing your your experience and wisdom in this August occasion. And we wanted to share, I will want to tell you that over 370 people have been viewing this webinar from all over India. And we have received rich compliments appreciating well conducted and useful and informative webinar from Dr. Tangaraj Saravanan, Dr. Kumaraban Armugam, Dr. Nagarajan Sarmugavelu, everyone. And Dr. Taiman has logged in from USA. He didn't want to miss the webinar. So I must appreciate the enthusiasm that he has got in attending this program. We have another, thank you, sir, and be with us if possible. And I have another eminent surgeon who has put in over 4 decades of service in surgery, in defense, and followed by now he's been working with us in the last 1 decade. I just want to ask Dr. M.S. Prasad. Actually, he comes, the initial also MS. Probably parents knew that he's going to become a surgeon also. So he's Dr. M.S. Prasad, MS. Dr. Prasad, the question I wanted to ask is, apart from sharing your experience, you would have seen gay emergencies in the non-COVID era. Now, COVID era, you have been operating here. I think most of the cases, acute abdomen, what Dr. Sabari presented, you have been with us. So how did you, what are the challenges you face, so that if you tell your experience and challenges, it will be useful for our delegates.
Good evening to all. Good evening to all who have tuned into this webinar. I must first thank Dr. Chandrasekhar for empaneling me. And I must say all our speakers, they have made an excellent presentation on case capsules encompassing a variety of GI emergencies. And my last speaker, Dr. Shabarnath, actually he explained more about surgery than GI. And those were the surgeries have been done by our team. I must say the COVID pandemic has been a real challenge, not to just surgeons, everyone. It left no aspect of human activity untouched. Be it a common man, be it a patient, be it a doctor, be it a surgeon, every one of us faced enormous challenges. As a surgeon, I must say, the problem started with from admission time onwards to the post-operative care. That admission, we always see the patient, whether he's COVID positive, COVID negative, we don't know the status. So naturally, we exercise a lot of caution, wearing our PPE and keeping the patient at a distance. That itself rather plays, a kind of a lack of real rapport between the doctor and patient. The touch, that healing touch is missing. Carefully, we avoid touching the patient and hardly we auscultate unless really essential. And once, we decide to operate upon, then we have to get the patient's COVID status. That itself becomes a little difficult. But fortunately, Tamil Nadu is one state where the availability of RT-PCR has been very easy. And I don't think we really faced any problem in getting the RT-PCR test. Overall, the patient, number of patients coming to the OPD has certainly, there is a 40 to 50% fall. And emergencies also is the greatest enigma, how surgical emergencies have come down. But they also found out that the ratio between the disease and the procedure has remained more or less same. There is no significant difference between the number of patients admitted with the diseases and number of procedures required for those diseases. The ratio remained more or less same. And that's not our study, of course. It was done by Italian group. And once the patient is decided upon to be operated, and in the theater, we are not really prepared to have that negative pressure theater. So we had to exercise a lot of care wearing the PPE. And I must say, wearing the PPE and doing the surgery is a real challenge, especially putting the shield. A lot of fogging will occur, and that obstructs our view. So after some surgeries, we have taken a calculated decision, we'll do away with the shield when the patient is COVID negative. That's how we somehow managed. And Dr. TSC has clearly explained, there are certain receptors in the biliary tract which play a role for COVID to invade that system. And the laparoscopic surgery generates a lot of aerosol. So in the initial stages during the 2020, a lot of laparoscopic surgeries were avoided. And we too were hesitant to take up. But later we realized with the PPE kit, we can do. And unless there is a positivity of the patient, we rarely refuse to anybody who required surgery. And we carried out laparoscopic cholecystectomies eminently. And some of those two cases which Dr. Sabari presented, they were real challenge for us. Because of the delayed presentation, Dr. Jailal very lucidly explained the delayed presentation of the patient and how they came with more complexity and how the problems were compounded by financial difficulties. All these things we faced, certainly. And that patient who was who had perforation of the duodenum, it was a real challenge. She was very obese, 105 kilos, and she was having a chronic liver disease. She was having a chronic venous ulcer with insufficiency. With such patient, when we were struggling to mobilize for surgery, another patient landed with a similar problem with a perforation of the ileum. So together, these two patients, that was enough challenge for us for that week. Anyhow, we successfully managed, and they are happily living, and we are reviewing the patient. And this is one of the, this is one of the patient, a duodenal perforation patient, a great experience for us. I must say, overall, the COVID experience taught us many lessons. And these lessons are just not that we will just forget and carry on. It is for us to see that the future we maintain certain level of caution so that we don't enter into the third phase. And we had many unfortunate events we heard on the news, and that type of no bed availability, no oxygen, no medication, no surgery, that kind of situation We sincerely pray that that doesn't again come. And we, being a non-COVID hospital, we have been managing our patients eminently. Most often, what I faced was the difficulty in discriminating the non-COVID pneumonia from COVID pneumonia. My previous speaker, he has clearly explained one patient how the pneumonia, what presented there, bronchopneumonia, was very difficult for us to know whether it was COVID or not. CT findings say it's COVID case, RT-PCR negative, and this patient was not having a proper oxygenation. She was obese, not able to take breathing properly. And in that situation, we almost thought the patient would lose. We would lose the patient. So that kind of situation was one of the difficult things for us to overcome. I must say, overall, we managed these 2 years of COVID with aplomb, I will say. Every patient was taken care of. All surgeries, whatever was required, we have done. Sir, do you have any other question?
Yeah, I think you have shared your thoughts very nicely. I just will come back to you after the first round of. We have 2 questions to each speaker from our panel and from our delegates. Thank you, sir. Thank you for your sharing your thoughts and experience with us. I just congratulate our speaker once again because many people have complimented us, Dr. Jairaj, Dr. Shankar Shekhar, Ayush Singh, everyone. The question to first speaker is from Dr. Taimanavan. Dr. Taimanavan asked, there are 2 questions. I will just tell you the questions so that you can answer. How about drug-eluting stent in such situation where you have done a wonderful job, but is there any scope for or the hope? Scope and hope. At least first there should be hope, then there's scope. Therefore, a drug-eluting stent in such a case is number 1. Number 2, you have done the third case or second case, biliary obstruction, doing a PTBD or ERCP, and gastric obstruction is stenting. Why not you? Why you did not think of US guided GJ and biliary drainage in such situation, or was there any contraindication? If not, what are the contraindication for this US drainage of bile and GOO? Both the question you can take up.
Thank you. Thank you, sir, for asking those questions. Going to the first question, whether is there a role for any drug-eluting stent? That is a very important thing. Actually, that idea of drug-eluting stent actually came from coronary. Indication was actually coronary to prevent atherosclerotic plaques from forming. So they used tacrolimus and paclitaxel-based coronary stents to begin with. And this idea was actually borrowed from a cardiologist. There are some human trials where these drug-eluting biliary stents was deployed in humans. Those studies have actually come from Korea. And they found that there is not much of a difference between these drug-eluting stents from non-drug-eluting stents. But that study actually concluded by saying that yes, it is feasible and it is safe to put these stents to avoid tumor ingrowth. But practically, we are not using that and it's not widely available. Coming to the second question, the question was about, is there a role for US guided drainage for both say biliary and for tackling gastric outlet obstruction? For US guided biliary obstruction drainage, we need to have a duodenum which should be not infiltrated with tumor. This patient had an infiltration of the duodenal bulb, and therefore a US guided choledochore duodenostomy was not technically possible. Of course, there is one more option, like to do a hepaticogastrostomy to tackle the biliary obstruction, but that is supposedly more moribund and it is associated with more complications compared to a US guided extrahepatic biliary drainage procedure like a choledochore duodenostomy, and that's why it was not considered. Of course, studies have shown that US procedures are safer compared to a PTBD procedure, but in this case, it was not feasible. Coming to gastric outlet obstruction, there are two options if surgery was not available or not doable. One is to place a enteral stent like what we did in this patient. The other one is to do what is called a US-guided gastrojejunectomy. That is latest in the field of US-guided therapeutic interventions. That is usually done by creating a port or by distending the jejunum, especially the first part just beyond the duodenojejunal flexure. And we visualize that under US guidance, and we puncture transgastrically directly to the jejunum, and we place what is called a lumen opposing stent. So these stents actually come with a tip which is electrocautery enhanced, and it is a direct procedure being done. But this patient had a tumor which was infiltrating quite up to the mid-body, and therefore we couldn't find a place, a conducive place where we can puncture and put in a stent. And therefore we thought that enteral stenting is practically easier and feasible in these patients.
Thank you, Dr. Gokul. There's another contraindication. I think you mentioned it. US guidance, there shouldn't be any ascites also. Sometimes if you have ascites, then you won't be able to do the GJ also. And you may recall that we did the US guided GJ first in this part of the country in one of the surgical conferences. So we were looking for an opportunity, but here this, as you said, the body is involved, and there will a little bit of ascites also may be the reason. So thank you very much for sharing your experience with us now to the delegates. And we have several questions to other speakers. I just want a brief answer. There are two questions to Dr. Raju Yogesh. One is related to the third patient. I'll ask both the questions to you. You said a post-operative recurrence benign. What is the cause of recurrence in this patient? Number two question from a GA resident. Is it sigmoid colon diverticulum more common diverticulitis? If so, why?
Let me take up the first question. The first question was that the recurrence, right? There are certain risk factors why an anastomotic stricture occurs. Most often during the post-operative period, there would be some kind of a local complication like ischemia. Those patients where there is a minimal, even a minimal leak, those are the patients which go for a stricture. And a low anastomosis is another condition where usually it's more prone for a stricture developing. Any post-operative hypotension in which at the anastomotic site, there is an amount of ischemia because of which a recurrence can develop. So usually the post-operative period, if it's associated with any pelvic sepsis or a perianastomotic infection, that is when the recurrence is most common. And then coming to the second question of why a left-sided diverticulum is more prone for diverticulitis is basically because of the stool nature which is present in the left colon, which is considerably different from a stool which is present in the right colon. Right colon, the stool is more fluid. There's less number of bacteria as compared to the left colon when it comes to the right colon. So stool just doesn't get inspissated into the diverticulum. It doesn't block the diverticulum when it comes to the right colon. Whereas in the left colon, the stool is well formed, more hard. The number of bacteria or microbiota is also considerably different as compared to that of the right colon. That is the reason why a left-sided diverticulum is more prone for diverticulitis.
Thank you, Yogesh. I think one of the reasons you mentioned is ischemic strictures can happen. And the other one is the Y sigmoid because of this solid stool. Okay. I think we have more questions to you, but we need to have the questions to have for other panelists here, other speakers. We have questions to Dr. Satyamurthy is there. Okay. Dr. Satyamurthy, you have two questions from the delegates here. Diverticular bleed, you have managed very successfully hemoclip. Is it a common procedure or you were lucky that you could manage it? So what is the message you want to pass on to the thing? If it's a mild to moderate where you could see the lumen of the diverticulum, you'll go for clip. I have my doubt, if you clip it, the blood get accumulated within the diverticulum. Is it a risk for the precipitating the rupture of the diverticulum? One. Number two, or if you have a torrential bleed, straight away you go for intervention radiology. Number one question. Now you are very lucky and you are fortunate that you had a covered metallic stent in ERCP following a bleed. Suppose had you not had this covered metallic stent, what would have been your take and how you would have, you said you are saved and the patient saved, but now the stent is not there, how you would have saved the patient?
So I'll take up the first question regarding the diverticular bleed. So we are lucky because there was only one diverticulum which showed that bleed, and it was a very easy for us to place a hemoclip as a temporary measure. But rebleeding rates are still there. But in this COVID era, minimally invasive techniques, we had the option of putting a clip, and the patient was hemodynamically stable also. If there is ongoing bleeding and we are and there are multiple diverticuli where we can't exactly pinpoint which diverticulum had bled and hemodynamic instability is there, then those are the patients we need not waste time in identifying the exact diverticular where it is bled. So we can directly plan a CT angio and do a selective angioembolization. So the second case, so we had that facility of the fully covered metal stent. So we were lucky enough to place that stent to have a radial compression of the entire CBD. In other ways, it is very difficult to manage this. We should be well prepared before taking these type of patients like portal biliopathy. We should expect bleeding complications after an intervention in the CBD. So we should be well prepared with the surgical team ready, and the interventional radiological team should be alerted when such an torrential bleeding happens. So and select, again, CT angio can be planned and coil embolization can be attempted. Rather, we have to subject them for more moribund surgical techniques, these patients.
Message to the delegate, both the time you are little lucky. The diverticular bleed was mild to moderate. You could locate the diverticulum and you would clip it. Fortunately, it didn't have a recurrence of bleed. But the message should be that you see the lumen. If you're able to do that diverticular, you can manage the hemoclip. Despite the hemoclip bleeds, then interventional radiology, or right from beginning torrential bleeding, you know that it's going to be diverticulum. I think you will have a CT angio followed by the interventional radiology, and angioembolization will be the answer. Second thing, what I want to convey the message here is, anyone doing ERCP, you must be well equipped with all the, you should be having all armamentarium. You should not search for the covered metallic stent at the time. Once in a way only you're going to have a massive bleeding like that. In 2-3.5 decades of my experience with ERCP, doing several thousands of ERCP, I did have one post-sphincterotomy bleeding that was not a cirrhotic patient. That time no covered metal stenting was available. He was immediately after the sphincterotomy, he developed tachycardia, hypotension. We had to really resuscitate the patient. Immediately we shifted to interventional radiology. Radiologist, he did the angioembolization of this. So the point to be noted here is, towards the apex of the thing, unless it is warranted, don't do a very full-length, wide sphincterotomy just for completion's sake. It depends on what is the need you have to. Suppose you want to put a plastic stent, you don't need to do a full-length sphincterotomy, number one. Number two, you have a small stone, You don't need to do a full-length sphincterotomy. This is the message I want to share with you. And thank you, Satya, for sharing your thoughts with us. I have two more the questions to Dr. Sabari. You said you had some problem in post-op pneumonia versus COVID-19 pneumonia, right? How did you differentiate? The delegate had asked the question, I know you would have done RT-PCR, you would have done the CT scan, you would have discussed with the radiologist, and the radiologist would say that something suggestive of COVID-19. Is there anything, I know you are not a pulmonologist to ask you, but is suggestive of COVID or non-COVID? And just want to ask you whether any bronchial washing need to be done to make it confirmatory that this is not COVID pneumonia, this is only post-op pneumonia. That's my first question. And second question, was there in the COVID-19 you had managed a COVID negative patient only? Was there any issues with the prolongation of hospital stay? You need to have a higher antibiotics such a patients or need to cover them? These are the two questions from our delegates for you.
Thank you, sir. First, I will answer the first question. The first question is about how to differentiate the post-op pneumonia with the COVID pneumonia. In our case, it was involving the right side predominantly, whereas in COVID pneumonia, it is generally it is a bilateral ground glass opacities. But this patient has got a consolidation changes. So our radiologist was very much sure this is only an post-operative pneumonia, unlikely a COVID-19. COVID-19, it's like a ARDS type where you will find a lot of ground glass opacities on the both sides of the lung. Considering doing a bronchoscopic lavage, when we have a doubt this patient has a COVID pneumonia also, so it also carries the risk of exposure. So better we will go with imaging modality and with the RT-PCR, which is commonly followed nowadays. Coming to the second question, since this patient presented very late, patient ended up with complications like ileal stricture with the perforation with adhesions, and also there was some evidence of sepsis. So they required higher antibiotics and prolonged hospitalization. So we need to educate the patients. They should come to the hospital at the earliest when they have acute abdomen features. Thank you, sir.
Wonderful, Dr. Sabari, for the nice explanation. I think post-op pneumonia and COVID pneumonia is so difficult to differentiate, and you gave a nice points to. Now, I want to sum up. After that, the pleasant task of vote of thanks, the seminar would end here. And I must congratulate my colleagues, Gokul, Yogesh, Satya, and Sabari for their wonderful effort. Taking for a few weeks to prepare for this topic and nicely putting in forward to the delegates. I'm very glad that over 400 delegates have logged into this webinar. That shows how important the topic is. And I am very hopeful that this is whatever the message we have given be useful to our delegate. Few from whatever I listened to the other speakers and my panelists and the delegates, few things the consensus I could arrive at that delay in reporting causes more morbidity and mortality. COVID-19, even though it's declining, it is going to stay with us for a few more days or a year too also. Be prepared for the third wave, and you should successfully manage third wave if at all it comes, better than the first wave and second wave. Third thing, while thinking of only COVID-19, we should not miss the non-COVID, be it a GI emergency or cardiac emergency or any other emergency. You have to give due recognition for this, and don't hesitate to manage such a thing. And all the delegates to the public, and should reach the message that vaccine is the only savior until entire country gets vaccinated, till entire world gets vaccinated. And the only thing is social vaccine, mask, and social distancing and hand washing alone will save this world, save all of us. With this, I hand over the mic to Dr. Gokul to offer the vote of thanks, and will end the seminar webinar.
Good evening once again. It's my pleasant task to thank each and every one of you for making this webinar a very successful one. So we had actually a discussion some time back, what topic to choose for this webinar, what would be the right topic. Thank you, sir, for choosing this topic on GI emergencies, real life case capsules. We really enjoyed preparing for these lectures. I think all the audience would also enjoy listening to these lectures as much as we enjoyed preparing for it. I would like to offer my sincere thanks to Professor Jailal, the National President of the Indian Medical Association, for having accepted our invitation to be a part of this program. Your inputs are really appreciated, sir. You told us how inordinate delays can be avoided when the patient is seeking for care in case of GI emergencies. And you also told that the ultimate benefit of all these scientific deliberation is has to go to the patient. That is somewhat, we really appreciate that. We also like to offer a sincere thanks to Dr. Ramakrishnan, the state president of the IME, and Dr. Ravi Kumar. Dr. Ramakrishnan has said how IMA is coordinating with the Tamil Nadu government in tackling this COVID-19 pandemic, how it helps in triaging patients and everything. You also told that unless the people behavior changes, it's very difficult to bring this pandemic under control. That was a really enlightening one. I also like to thank all my colleagues, Dr. Prasad, our senior surgeon, and also my gastroenterology colleagues, Dr. Satyamurthy, Dr. Raji Yogesh, and Sabarinathan for their excellent presentation and for the very interactive discussion. We also like to thank our sponsors, the Torrent Pharma, for sponsoring this program. We all agree with the fact that this Zoom platform has been a boon to all of us. We are able to have such webinars and also share so much of scientific data. I would like to thank our software engineer and technical expert, Mr. Sivanandam, for all the support we had today in the form of audio visuals. Thank you, Mr. Sivanandam. I'll also like to thank all the delegates who could participate in today's webinar. I'm sure that they would have got benefited from all the scientific deliberations that have happened today. Thank you, one and all.
Yeah, very important message I want to convey here. From August onwards, we are going to have international webinar, and every month one webinar will be there, or will be endorsed by American College of Gastroenterology and American Society of GI Endoscopy. We'll see international speakers also, international moderation also will be there, and don't miss this webinar. I want to put it in record the compliments offered by Dr. Santi, gastroenterologist from Railway Hospital, and Dr. T.K. Chandrasekhar from Madurai, and other delegates also. I'll be failing from my duty that if God has kept us very healthy and it's given an opportunity to share our experience to all our delegates. Thank you very much for this wonderful evening, and hope to meet you in our next webinar. Thank you.